Welcome to the Pharmacists Are In, a podcast made for pharmacists by pharmacists. Pull up a seat and let's get started.
Welcome to another episode of the Pharmacists Are In podcast featuring myself, Ajit Johal, and Ontario pharmacist John Papastergiou. So we are back, John, for another episode, and we just had such a great time with pharmacist Susie Jin on the last episode talking about vaccinations and diabetes. I think we should really take a deep dive into diabetes, and specifically what's the big thing about diabetes management is glycemic control. So there have been some really great advancements in glycemic control technology. I remember when I first graduated from pharmacy school, which wasn't even that long ago, people were poking their fingers. And now there are other more sophisticated ways to collect really great data. And I'm super excited about this episode. And I kind of want to start because I remember this topic in Pharmacy U Toronto. I saw you speaking about it. So tell me all about that, John.
Yeah, a lot of our work has been done in the kind of point-of-care diagnostic space, especially in chronic disease. Obviously, diabetes is such a huge part of that. And, finding ways to improve your A1C. I think when you think about A1C management, I mean, we've got a huge opportunity here in Canada. 70% of patients haven't had their A1C done in the last year. Almost none of them know what it is, and I think as we're thinking about this wave of patients that is going to come to pharmacy with either newly diagnosed diabetes or undiagnosed diabetes, the pharmacist is going to be expected to play a bigger and bigger role. And I mean, technology to me is one of these things that we've got to embrace as pharmacists, because it's going to be the only way that we can manage these patients efficiently and effectively. I mean, you see how busy it is in pharmacies already. We've got this massive, influx of new scope that are, if we're really going to spend, time with these patients, we've got to make each one of these visits more and more efficient. And some of the new tech that's coming, with respect to the monitors, it's super impressive. And I'm excited to talk about it today. And, it's funny, our audience is growing Ajit, and we're taking, ideas from the audience around topics that we could do. And diabetes is one that comes up all the time.
Oh, it definitely does. And actually, just to hone in on something you said about newly diagnosed, in Canada, I saw a statistic. When you add up the numbers for pre-diabetes and type 2 diabetes, it's about 11 million. And in a country of over 40 million people, that's a significant percentage. And actually, I think the IDF, the International Diabetes Federation, we rank the highest per capita or highest diabetics per population. So this is a chronic disease. And I know this is a buzzword that we've talked about on previous episodes. Pharmacists have to get plugged into chronic disease management, and it's inevitable. Minor ailments was just a start to kind of take the low-hanging fruit off the system. But man, chronic disease management is where you really create sustainable healthcare. If you can manage patients better, you don't have, for diabetics, I mean, I was a certified diabetes educator from 2015 to 2020. I still do diabetes consults. I just can't call myself a CDE because I didn't renew it. But one of the big things is preventing those microvascular and macrovascular complications, which are huge impacts on the healthcare system. So on your line about efficiency, what have we done with vaccines is pharmacists, and you have a really good story about how efficiently you do vaccines in mass. And the one thing we've seen, and we talked about previous episodes, is public health is looking at pharmacy and saying, how are you guys doing so many? And obviously there's no corners cut in safety, and people are getting vaccinated and properly, landmarking, etc. But when it comes to diabetes management, we need to find efficiencies, and something like continuous glucose monitoring is definitely one of those technologies.
Well, I think of where we were before, these devices came to market, and it was a very different time. I mean, patients were walking around with logbooks, and I remember it clearly. You get these, and I practice in a multi-ethnic, primarily Greek senior area where you get patients coming in. They didn't even know why they were testing. They're coming in. They've got these logbooks. They're writing in, you know, covered in oil, covered in feta cheese, and I'm like looking at these things, and I said, this patient's perfect. They've got perfect results. So the patients aren't dumb, right? So they would put in only the good readings, leave out the others. There's no context.
Hmm.
Was it before food, after food, when were it before? Like you just kind of guessing, and we'd have to spend time kind of scrolling through all that. Then, after that came the enhanced glucometers. It was pretty cool. These were cool tools. They used the apps, the data from the more traditional glucometers would go up into a cloud. And again, patients were required to download the apps. And we found, they were using them, but not really, nowhere near to the fullest extent. And I think it was awesome tech, but it required a lot from the patients, right? And I think especially our seniors patients, didn't really take off. And then bam, we got dropped with these continuous glucometers, and it was, I think, really a game changer. And Ajit, when you look at the data, man, I mean, simply, uh, using a monitor and doing a continuous glucometer and doing nothing else improves your A1C. I mean, this is pretty fantastic.
Totally. And I think one of the challenges that I've seen in diabetes education and practice is we need to be more patient centric, right? So like you were saying, like the constant, okay, well, you need to poke your finger 6 times a day, before meals, after meals, you're using basal insulin, you're using bolus insulin, and we're adjusting this insulin, and it's constant finger poking. And in pharmacy school, we tell patients not to go on the pads, but to go on the sides. That still hurts, man. Like it still hurts to do that. And also, like you're saying, it's such a burden on patients. And what I find is, like you said, the logbooks, but even the A1C appointments, obviously with COVID, they haven't been coming in, but every 3 months when we have someone who is getting an A1C checkup, it's always like, the past 3 months are just kind of wasted. You come in, and obviously A1C, for those who want a refresher, it's glycosylated hemoglobin. So red blood cells get sugary over time. And especially in the last month is really when it picks up. If your blood sugar is quote unquote not controlled, then obviously your blood will be more sugary and your A1C will go up. But what we're finding, especially in a variety of populations, which I'd love to speak about, who would benefit from continuous glucose monitoring, is this time and range. So every single day, patients are doing activities, they're eating different foods, they have different stresses. And when we look at time and range through something like continuous glucose monitoring, we see trends, we see patterns, we understand what works, what doesn't work, versus, we tried a medication, and say, for example, the medication is not even covered, so the patient doesn't even fill it because they go to the pharmacy and say, I'm not going to pay this amount. Go back to the endocrinologist, go back to their family doctor and say, yeah, I tried to eat healthy, but it's barbecue season. Oh, I tried to eat healthy, but it's Christmas. And, the patient's completely lost control, and their A1C keeps going up. And therefore, now we're looking at renal function being impaired. We have to get their eyes checked. And obviously, they probably have hypertension, dyslipidemia, and they're inching closer to that major adverse cardiovascular event. So with continuous glucose monitoring, it allows both pharmacists and patients to take back control on a day-to-day level. So you have the patient able to find out what habits work, what foods work, what doesn't work. It's very motivating to the patient. And for a pharmacist, I don't want to look at those logbooks. Like, I remember as a diabetes educator, people would hand me a logbook, and like, I can't. It's like reading a Sudoku puzzle that doesn't have an answer. Right? It's ridiculous. So
Yeah.
this is not like a nice to have. This is now a have to have. So it's really great that we're talking about this. And what we're going to talk about is where it's at now. And then ideally, what I want to do is spend the last 5 minutes and kind of look at the future of what it could be. But where it is now in BC, and I'll get you to chime in on Ontario. Currently, in British Columbia, we have BC Pharmacare coverage as of August 2023 for continuous glucose monitoring devices. And that includes the Dexcom G7. It's covered for patients on intensive insulin or an insulin pump. And I think it's the same across the country, if I'm not mistaken.
Yeah, I think it's the same. I don't know if the word intensive is included here, but you've got to be on insulin right now to get the coverage, right? And, there's an opportunity because I get asked about it a lot. Type 2 diabetics are interested in it. They're aware of the technology. They've heard about it. There's this idea, with patients that, if you don't have to prick, they get more value out of it. I think pricking, I mean, we all know the patients tell us in practice it's cumbersome, it's challenging, it's painful. They don't necessarily want to do it. So if you're able to avoid capillary blood, there's a lot of value there potentially for our patients, right? And
Definitely.
they're asking for it. And I think, we have to understand how this technology works. It is very different. We're not looking at capillary blood. It really is, the interstitial fluid that we're looking at. So there are some subtle differences there between the readings. But I mean, for the most part, uh, if you're able to interpret the data and you're getting a lot of data being collected, throughout a 24-hour period, you've got a real good indicator of how that patient's doing. And you touched on this idea of time and range. A lot of my work has been done in the point of care space, and A1C screening is where it all started. And there's value to screen A1C, but there's a lot of limitations there as well, right? You could have a good A1C, and this patient's blood sugars are all over the place, right? But they average out,
Definitely.
they got a lot of highs, a lot of lows, they average out, they look pretty good. But when you dive a little bit deeper and you get access to these blood glucose readings over a large period of time, you can see, hey, potentially the patient's control is not that good, right? They're having a ton of highs, a ton of lows. Really is our our role to smooth them out and get them within that, therapeutic range. And I think there's a cohort of patients that are missing that for sure.
Definitely. And actually, I have a really good story about what you mentioned about the A1C looks great, and therefore we don't need any intervention. When I was working in clinical practice in diabetes few years ago, I had a patient who had really advanced chronic kidney disease, and they were on a very intensive insulin regimen. And I was looking at their A1C, and it was like 5, 4.8, 5, 5.1, 5.2, which is well below, it's well in the target range. And what was actually happening is, because in chronic kidney disease, there's severe anemia. So there's a lot of erythrocyte stimulation therapy. So there was a lot of new reticulocytes or red blood cells that were being made immature that weren't getting glycosylated. So even the most severe manifestations of diabetes, chronic kidney disease, A1C is not accurate. And actually, I was reading a paper in Japan, they only use time and range. And the one thing I really like about time and range is, when I was doing diabetes education, the one big training we get as educators is, hey, we love people who hit targets, but the problem is we want to avoid the lows. That's priority number one, because if someone keeps getting lows, then they start to lose that sort of spidey sense of when they're starting to get low, and then obviously if you get below 2, you can actually pass out and faint and things like that. So the one thing that CGM does really well with the CGM device that's currently covered by BC Pharmacare and Ontario is the urgent low soon alert. So basically, it alerts users up to 20 minutes in advance of severe hypoglycemic events. So they can actually, bring their sugars up, eat a protein snack, all those things. And I really like that. And I think a good future idea is for elderly patients, because for frail elderly patients, they have different targets. Their time and range, I would prefer them even 50% of the time to be out of range, because they're only going to live 2 to 5 years longer, but I don't want them to have a hypoglycemic event. I don't really care about macrovascular, because that is more for my 40, 50-year-old diabetic patients who are going to live 30 years, right? So I think that every patient is so unique, and I think that this is really important. And to clarify, the G7 does the predictive urgent low soon alert. Other CGMs don't.
Yeah, I think it's important. So it's probably important for us to differentiate. There are a couple really on the market right now, right? There's the
Yep.
Libre the G7, it's probably going to become a more competitive space. I hear rumors of some other ones coming to market. And I think there are differences between the devices. And I think there's an opportunity for pharmacists to familiarize themselves with the differences, and they get asked. Obviously, there's a lot of marketing being done to patients as well, and they come in. And I find, with pharmacists again being pulled all over the place, they sometimes understand, the overall, technology, but they're not aware of the subtle differences. And that predictive urgent low soon alert that comes with the G7, there's a ton of value to that. I think a ton of value. And I think that's the real ability of this tech with all this data coming at it to be able now to predict where you're going to land based on your trend, right? And if you're able to alert these patients, you could, prevent some pretty serious consequences, and I think there's again a ton of value in that. And again, engaging the technology to play a more important role. I think it's a very exciting space.
Oh, definitely. And I think, yeah, to your point, exactly. I think the first thing we always look at is are we avoiding these lows? And even endocrinologists always asking for fax results of sugars, right? Pharmacy, please fax
Oh,
patients. So not only do you have your stained book, but you're faxing that stained book, right? So I think that's a really good feature to have. And obviously, if a patient's on insulin, that's a high alert medication on ISMP. That's a great start. I think it's great that the provinces around the country are covering this. But ideally, I would love to see this for both type 2 diabetics and pre-diabetics too. And mainly it's because people are motivated, right, John? People, if they understand, if they're newly diagnosed with diabetes, what's the first thing they always say? Can I reverse this?
yeah.
Can I make this go away? And what happens is they get discouraged because nobody talks to them, no one educates them, and then they go visit to visit and their A1C keeps climbing. But I think there's a good subset of patients that will obviously adhere to their medications. They will really change up their lifestyle, and this really helps support them. And obviously they get their vaccinations too, which also helps control sugars. I had to plug that.
Yeah.
But
I'm sorry, I was going to say you hit on a really important point because, the positive lifestyle modifying effects of these devices are well documented as well. Like simply going on a device and having, as a patient, having access to that data and having access to it in real time.
Definitely.
More, right? And we need that. I think as frontline clinicians, we need to really focus on strategies that engage the patient because we can't do it all and we don't have the time to do it all. So if you have this tool now that helps the patient get better involved in their own diabetes management, it's a win. And I think that hits on your point that, hey man, if we're gonna, have this tech available, let's get it into the hands of type 2 diabetics because that's where you're going to really have an impact with that group. If you could get them to change their lifestyle, modify their lifestyle, right?
Definitely. I think that's the big thing, and that's why what I really like what Ontario is doing with their meds check. Because in BC we have medication reviews. They have a diabetic meds check, and that allows you to hone in. And I think the reimbursement's higher for that. Allows you to hone in and kind of and help people manage this condition. It's not based on how many medications they're on, because whether your journey is pre-diabetes or whether you're all the way at the point of chronic kidney disease, there's always an opportunity to live a better life with the condition, right? So I think that's really important to note. So John, basically, I think what our listeners would want to know is, like, if a patient comes to you at the pharmacy and asks, "Hey, what do you think of these continuous glucose monitors? My neighbor has this thing that they kind of put in their arm and it monitors their sugars, and here I am, writing this out in a booklet." What would we advise pharmacists to say, and what should they look into to best inform their patients?
Yeah, for me, I mean, it's a no-brainer. You encourage them, especially if they're asking you about the tech, to adopt it, right? And I think
Totally.
this strategy is no different than the strategy we use with vaccines, because there's always this perceived barrier of cost. And listen, there's going to be patients where there is a cost barrier, and I know we're going to have some that have it funded, others that don't. a lot of the third parties are covering it as well, and we haven't really talked about that, right? So party coverage will vary, but I think it's our responsibility to make that strong recommendation, right? And I think the value is there. We know the value of these machines. They engage patients and take better control of their lifestyle. We have more access to data. There's things like the predictive load built in. So all these things add value to the point that simply using the device reduces your A1C up to 0.05%. That's a big win, eh? Some medications don't do that, right? So
Yeah, the effect size of some medications are that, if that.
Right.
And you have to take that every day and have the side effects. So totally.
Yeah, so my advice to that pharmacist that's kind of thinking about it is, I think you make that recommendation and work with them. And if there's some barriers you have to overcome or some hurdles to get them on it, okay, we'll try to do that. But there is value and sympathy. These are game changers, in my opinion, right?
Yeah, though they definitely are game changers. I would probably say the next thing is, and I agree with you with the strong recommendation, is understanding the access pathway for the patient. So it's one thing to say, yeah, no, I think it's a really good idea. I highly recommend it. And obviously supporting the patient with positive reinforcement to use a technology to better manage their diabetes. It's worth its value in gold. But also understanding how do they access it, how much it would cost, and how they would use it, how you're going to support them, and how to insert the device. So I encourage pharmacists across the country is understand who qualifies for it, whether they're covered for it, whether their extended plan covers it. But even if it doesn't, obviously the cost of the device and the sensor is definitely worth the value, but it's worth it if the patient's motivated, and obviously if they're asking about it and working with you as their pharmacist, they would be. I think like the big thing about the continuous glucose monitoring is that lifestyle change, right?
Yeah.
So like with that, it's not just, hey, use this device, stick it in your arm and don't change a thing. It's about, everything that goes into what you're doing with that data, and how you are, being accountable to it, and you're being supported by a healthcare professional. Actually, for the BC criteria, even for insulin dependent diabetics to be covered for it, they have to have access to an educator or a team, right? So you have like a coach.
Yeah.
So I think like, John, to basically, I know we could talk about this all day, and I'm sure there are going to be more episodes on this as we get into the nitty gritty. Because all of this fits. Vaccinations, point of care testing, chronic disease management. What a great tool this is. But the one final thought is the pharmacist as the coach, right? The chronic disease management coach, the person who's the medication expert, knows what vaccines you need, knows what technology you need to use, and is your sort of quarterback in managing your care. And I don't want to step on any toes here, because I know you're from Ontario, so there's a lot of a bit of friction between family docs and pharmacists. But I think a lot of the doctors that I know, they just want their patients taken care of. So I think that the pharmacist as the coach on that maintenance for the pre-diabetes, type 2 diabetes, huge role. And this is a tool if you're going to do chronic disease management, because that's coming, John. That prescribing for those conditions, it's coming. You have to know about this.
Oh yeah, that's our next piece of scope here. I think minor ailments is going to land any day soon. The expansion of that program, and I think we're not gonna move directly to the Alberta model. I think where there's huge opportunity is chronic disease. This space, we know primary care physicians. It's tough for them, and this is, like we said, this is an epidemic. Right, that we're seeing, right? Like when you're talking about 35% patients potentially, or people in Canada potentially having this disease, there's no way primary care physicians can manage this on their own. They're going to need frontline pharmacists, and we're going to struggle with it as well. So we're going to need cool tech and everything else to help us. But a big part of it will be the patient engagement side and getting patients more involved in their own care. And this is where I think this stuff is great. And I agree a little bit. I think physicians right now, there's some of that dynamic tension, the friction. It's out there. There's a lot going on with our push forward with scope. But I think once the dust settles, they're going to be quite supportive of it, and it's if they need us. And I came back from Cape Town, South Africa, and I presented some data there, and it kind of fits with what we're talking about. But what we looked at was the role of community pharmacists in point-of-care A1C testing, right? And we tested a lot of patients over a span of 6 months, like 10,000 of them. So this is not a small. But the things we looked at was there any difference in the A1C of these patients if they were attached to physicians and if they weren't, So do they have a primary care physician and or didn't they? And what did you think happened, Ajit?
I would probably say like it didn't make a difference.
It didn't, and I didn't make
Yeah.
any difference. No statistical difference. It wasn't even a trend to improve. It was nothing. It was pretty much exactly the same. And I think it's not because physicians don't want to manage these patients. They're not well-intentioned. It's our healthcare system is very reactive. You go into your doctor, got a problem, we try to solve it. Oh, diabetes is getting worse. Okay, we'll try, we'll up your meds. No one's taking a proactive approach. So when these guys are presenting to pharmacies when A1C, there's no difference. They're the same. So we gotta try to move that needle. And I think this tech is going to help.
I think so too, and I think I really like that study that you presented, and I only know the answer because we talked about it before.
Yeah.
But just because someone's attached doesn't mean it's hard to quantify that level of care. There's
Oh,
a
yeah.
lot of variables. We were talking about that about is this technology the end all be all? No, but it's part of a full suite of care, and obviously, right medication. The technology helps. Diet, lifestyle, what the patient does on their own is really important, but they need someone to kind of be accountable to and have someone monitor, and pharmacist is just so well positioned. So hoping our healthcare system kind of makes that shift sooner rather than later, because it is an epidemic, John. And the thing is, like, this isn't minor ailments.
No,
These aren't self-limiting conditions that are
no.
inconvenient. These are conditions that, if they're allowed to manifest, this could turn into chronic kidney disease. It could turn into
Yeah.
end-stage renal disease. It could turn into heart attack. It could turn into stroke. It could turn into heart failure, right? So, we're looking at a huge wave crashing in the next 15, 20 years, and we need to get on top of it now. But promising technology, and obviously promising role of pharmacists. It's just a matter of putting everything together, which I think we definitely can do.
And then, as I think, you spoke about where we're going with this. Imagine all this data right now coming in through these devices and the role that AI is going to be able to play once it gets integrated into these devices. We have the predictive urgent low kind of alert now. But
Yeah.
imagine once, you really start training the AI on the kind of whole gamut of situations that are coming up in these patients. And we talked about time and range and everything else. There's going to be a lot of predictive value here. The AI is going to be able to trigger, I think, alerts that go beyond just the lows. And it's just going to be very interesting to see where this goes. And I think the pharmacist is going to be the one, and they're the most ideally suited to interpret this type of info, right? It's going to be us they're coming to. We see them more often than anyone else. We know these patients with diabetes on average are in our pharmacies 12 to 13 times a year. They're not seeing their physicians maybe 2 or 3 times a year, right? So they're having these conversations with us, not anyone else, and they trust us more than anyone else. We got to figure out how we're going to balance all this.
We do, and I think you said it really, really well. There's a great incorporation of AI. AI can take in large chunks of data, but as healthcare professionals, we're the ones who really interpret it. So with that, I think, like I said, John, we could probably go on all day on this topic, and I'm sure we will be taking this even further when we start to get into the nitty-gritty of clinical application and case studies. But for now, I think that's a great intro to the technology available managing diabetes, and always a pleasure, John. Until next time.
See you soon, bud.